Okay. Hi, everyone, and welcome to our Dysphagia Awareness Month webinar presented by our Mission Lifeline Post-Acute Stroke team. I'm Madeline Pulaski. I'm a program implementation lead for the American Heart Association and happy to be with you all today. We are very excited to hear from a panel of dysphagia experts to discuss our acute post-stroke dysphagia and the role that all providers have in the care of those patients. Oh, sorry, my slides aren't going here. This live event is approved for 1.5 continuing education hours, and you'll receive an event after the webinar today that details how to get those credits. We do share a disclaimer on all of our webinars, so I'm going to read that here briefly. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any products or device. So before we get started, we're just going to have a few housekeeping items here. All of our attendees are muted today, and only our panelists will be on camera. There is a Q&A button at the bottom of your screen. Please feel free to put questions in that section at any time during the webinar today, and we will have a live Q&A after all of our speakers have concluded. If you need closed captioning or would like to use that feature, there is a button that has 2 C's on it at the bottom of your screen. Feel free to click that. The session will be recorded and we'll send that out afterwards. And the slides are available as well. So if you click the resources button, it looks like 3 pieces of paper at the bottom of your screen that will get you to those handouts. If you guys have any technical issues today, our best fix is trying to log out of the webinar and log back in. You can also check your internet connection. If you guys do experience difficulties, feel free to email me. I'll type it in the Q&A. It's madeline.pulaski@heart.org, and I'll do my best to help you out. Owen is on the screen there too. And with that, we'll look at briefly our agenda and our speaker disclosures. I'm going to flip through these rather quickly, but you will have access to these afterwards. And there's our objectives for today. And with that, I'm thrilled to introduce our speakers. We are joined today by Dr. Heather Bonilla, a professor and graduate director of the doctoral program at the University of South Carolina, Dr. Erin Reedy, the assistant director of speech pathology at the University of Rochester Medicine, Dr. Brittany Kreckler, an associate professor at the University of Cincinnati Health, Dr. Yanina Wilmskirter, an associate professor at the Medical University of South Carolina, and Caitlin Schlosser, a program manager at the American Heart Association and speech pathologist at Swedish Medical Center in Washington State. So thank you to all of our panelists for joining us today. And with that, I will hand it off to Dr. Bonilla.
Let's see. Thank you so much. Super delighted to be here. Thank you to the American Heart Association for hosting this. This is a topic that my colleagues and I are really passionate about in a way in which we think we can pull together some of the information out there to really improve the way that we care for our patients. So we will go ahead and dig in. Swallowing is one of the most complex sensory motor functions in the body, involving more than 30 muscles, 6 cranial nerves. Swallowing impairment, also known as dysphagia, is difficulty moving food, liquid, medication, and/or saliva from the mouth down through the stomach. Disruption at any point of this process can affect swallowing safety and efficiency, and dysphagia can result from impairments in strength, timing coordination, and/or sensation. This is an image from a fluoroscopic swallow study. And as you'll hear later from Brittany, this study allows us to identify specific physiologic impairments that contribute to dysphagia. Without understanding that underlying physiology, treatment decisions are often based on observed symptoms rather than diagnosis. This is important because dysphagia is not benign. It is associated with aspiration pneumonia, malnutrition, dehydration, longer hospital stays, and higher readmission rates. It also limits our participation in rehabilitation and impacts overall recovery. These complications rarely result from a single event. They emerge across the care continuum meaning prevention requires coordinated action across multiple disciplines. One of the clearest examples of these downstream consequences of post-stroke dysphagia is pneumonia after stroke. Among these medical complications, post-stroke pneumonia is associated with the greatest excess mortality of any medical complication after stroke and is a major contributor to poor outcomes. An important point that you'll hear more about from Caitlin is that preventing pneumonia is not the responsibility of a single clinician or intervention. It really requires coordinated assessment, management, and prevention efforts across the stroke care team. Dysphagia affects outcomes that matter to every discipline involved in stroke care. And this is one of the main messages that we want to get across with this webinar, is that it really is a care team issue. Taken together, these effects of dysphagia make it way more than a swallowing problem. It's a systems level issue that influences outcomes across the entire stroke continuum. And while it is a clinical problem, it's also an economic one. Recent Medicare analyses show that post-stroke dysphagia is associated with approximately $11,000 in additional inpatient costs after AIS and nearly $18,000 after ICH. When multiplied across the hundreds of thousands of strokes that occur annually in the US, this results in billions of dollars of additional healthcare spending. All these data come together to reinforce the need to improve dysphagia care now, while preparing for future pressures created by the aging population and continually rising healthcare costs. Importantly, dysphagia is extremely common after stroke, way more common than most people realize. In prospective studies using swallowing imaging, approximately 80% of patients demonstrate some degree of swallowing impairment after stroke. One reason that dysphagia affects such a large proportion of patients after stroke is that swallowing depends on a distributed neural network. Therefore, stroke can affect swallowing through direct injury to the critical region or a disruption of any of the connections that coordinate this complex behavior. Despite being so common, dysphagia remains both underdetected and underdocumented. When diagnosis is not identified or not recorded and carried forward in the medical record, patients miss critical opportunities for care. The degree of this issue was recently brought to light when I led a study investigating barriers to the rehabilitation pathway for patients with acute stroke and found that in the American Heart Association Get With the Guidelines stroke data, so this was a review of data from 2010 to 2019 of approximately 2.7 million patients that met that study inclusion, dysphagia screening was reported for only 70% of patients during that acute hospital stay for either acute ischemic stroke or ICH, with only 17.2% of those patients failing the screen. That means 53.4% passed the screen. When we compare this registry data of 17.2% of patients failing the screen with the prospective imaging data that show nearly 80% of patients have some swallowing impairment post-stroke, two concerns emerge quickly. First, many patients are either not being screened or the screening is not being documented. Second, many patients who are being screened probably are receiving false negative results, likely because of use of non-validated tools or implementation challenges in screening. Understanding why these numbers differ is critical because screening is often the first step in identifying these patients at risk and getting them on the dysphagia care pathway. Erin's upcoming presentation will focus specifically on swallow screening and the factors that influence its effectiveness. However, unfortunately, dysphagia screening and identifying dysphagia is only part of the challenge. We also face significant barriers in accurately documenting and tracking its true prevalence. One large additional challenge that impacts both clinical care and research that depends on accurate administrative data is the known undercoding of post-stroke dysphagia. Gonzalez, Fernandez, and team found that only 22.8% of patients with dysphagia actually had dysphagia coded in their medical record. That means that 77% of patients with post-stroke dysphagia lacked that diagnostic coding. This diagnostic undercoding likely occurs for several reasons, one of which is that acute stroke care is delivered within a bundled payment model that does not depend on accurate dysphagia coding for reimbursement. I also believe that it occurs because the acute care teams rarely receive feedback about the downstream consequences of dysphagia that is missed, undocumented, or inadequately managed. These findings highlight the need to continue to strengthen acute dysphagia care, as failures in early identification and management can have significant downstream consequences throughout the recovery trajectory. Here, we've made a simplified pathway that illustrates a series of critical decision points that occur. Patients are hospitalized. Dysphagia is then identified or missed. Management decisions are made or deferred. And patients then transition to the next care setting where dysphagia may be recognized and addressed or may continue to go unnoticed. A key point here is that a documented diagnosis of dysphagia in the acute care setting is absolutely critical for access to care after discharge. It drives referrals, insurance authorization, service prioritization, and payment for services in rehab settings. If dysphagia is not clearly diagnosed, it may not be addressed later. In many systems, a diagnosis that is not documented effectively becomes a diagnosis that does not exist. We have interventions for dysphagia, but they only work if patients gain access to the appropriate services. When dysphagia is not documented in acute care, opportunities for intervention in post-acute settings are often lost. Importantly, recovery is not linear for patients with post-stroke dysphagia. So diagnosis is not a one-time event. Many patients show early spontaneous recovery, especially in the acute phase. But recovery is highly variable. Some patients improve quickly, others more slowly, while some have persistent impairment or even worsen. The key point here is that dysphagia status at discharge is not the final state. Reassessment is needed. Dysphagia status is a snapshot of swallow functioning, not necessarily an accurate prediction of a long-term outcome. Because dysphagia is dynamic, follow-up is essential. Reassessment only occurs when it's clearly planned, documented, and communicated. If expectations for reevaluation are not established for patients, their care partners, and providers, the pathway often ends at discharge. This is where the system often breaks. Patients leave the hospital without a clear diagnosis, without a plan for reassessment, and without clear ownership of follow-up. And importantly, oral intake restrictions, including NPO status in G-tubes placed in acute care settings, are frequently interpreted downstream as permanent rather than provisional. When this happens, oral intake restrictions become a substitute for a diagnosis and a plan, rather than a temporary management strategy. Yanina will address this issue later in the webinar as she discusses oral intake decisions and G-tube placement after stroke. When oral intake restrictions become the endpoint rather than a temporary management strategy, dysphagia effectively disappears from the care plan. The challenge then is ensuring that dysphagia remains visible as patients transition out of acute care. So knowing all of this, the question becomes, what should happen before a patient leaves the hospital to prevent this breakdown from occurring? This dysphagia discharge planning and keeping dysphagia in mind during discharge planning is one of these important inflection points. 4 things should occur. Dysphagia needs to be explicitly diagnosed. Probably got that point by now. A plan for intervention and reevaluation needs to be documented. Appropriate referrals for care for reevaluation need to be in place. And the patient and care partners really need to understand what comes next. If we miss any of these steps, the pathway often ends. The greatest risk to many of these patients is not that they have dysphagia, it's that this dysphagia becomes invisible. So the picture that I've painted so far may seem pretty discouraging. There is an important reason for optimism. Many of the factors that influence dysphagia outcomes are within our control, and meaningful improvement is possible when a care team works together. Dysphagia outcomes are co-created by the entire care team. Nursing identifies early concerns, implements recommendations, monitors tolerance, and provides ongoing surveillance. SLPs evaluate swallowing, establish the diagnosis, and guide management and reassessment. Physicians and APPs have critical roles of integrating dysphagia into overall medical decision-making and ensuring continuity across settings. Dietitians help patients meet nutrition and hydration needs safely. Physical and occupational therapists influence positioning, endurance, mobility, self-feeding, and participation in care. Stroke coordinators, case managers, and social workers help ensure that referral services and follow-up actually occur. And patients and care partners carry the plan forward after discharge across settings. Post-stroke dysphagia is not a single clinical event. It's influenced at many points along the longitudinal care pathway. Outcomes are shaped by a series of decisions across people, settings, and time. And importantly, everyone, not just SLPs, play a critical role in these swallow outcomes. So if dysphagia care is a longitudinal pathway, and if outcomes are shaped by decisions across multiple settings and disciplines, the next question becomes, where does that pathway begin, and how do we ensure that patients successfully enter it? That's where we will focus next as I pass this on to Dr. Reedy.
Thank you, Dr. Bonilla. Okay. Right. So I'm going to be talking about swallow screenings versus swallow evaluations. We'll get into the differences, why screening is important, and what are important factors to consider during this evaluation process. So, oops, too many slides there. So swallow screening versus an assessment. I think that this is an important distinction to begin with. So swallow screenings can be performed by any trained medical professional, but must be able to be completed 24 hours a day, 7 days a week, and 365 days a year, which is a lot of times where why nursing is responsible for providing swallow screenings. Swallow screenings are designed to be quickly administered and documented with only a pass-fail outcome. And all patients who fail should be kept NPO, nothing by mouth, and be seen by a speech pathologist. This is distinctly different from a clinical swallowing evaluation, which is only performed by a speech pathologist. There's multiple components to the clinical evaluation, and there's significant knowledge and skill required to perform the clinical swallowing evaluation, and oftentimes a lot of gray area in terms of interpreting the patient quote-unquote performance, forming the clinical recommendations, and determining the need for swallowing imaging, which we'll talk about a little bit more in Dr. Kreckler's portion. So why perform a swallow screening? Swallow screenings are an important part of the acute stroke protocol and help to identify patients who may have dysphagia. Swallow screenings have demonstrated significant benefits to patient care and patient outcomes, including reducing the risk of pneumonia, reducing the length of stay, and reducing overall mortality rates. It's also included in the American Heart Association Get With The Guidelines. So the goal of swallow screening is to provide early identification of patients at risk for swallowing impairment. And then two significant factors in the outcome is that the validated swallow screenings protect the patient from receiving oral intake when it would not be safe, but it also protects the nurses from administering anything oral, including medications, when it's not safe. All validated swallow screenings include a portion that we can refer to as a swallow challenge, commonly 90 ml or 3 ounces of plain, unthickened, unaltered water, which is a critical aspect of the screening process, as silent aspiration is oftentimes volume dependent, especially in patients with neurologic impairment, such as post-stroke. Swallow screenings might sometimes seem like an additional step in an already lengthy process in the post-stroke patient care pathway. But it's a critical step because validated swallow screenings can reduce the time spent as nothing by mouth or NPO for certain patients, the patients who pass, which also includes the ability to administer oral medications more timely for patients who pass. And again, this is typically why nurses are the go-to discipline for administering swallow screenings, as they're staffed 24 hours a day, 7 days a week, whereas SLPs are typically working during day shift hours. Additionally, the timely completion of the screening and documentation and communication to the stroke service for the patients who fail a swallow screening allows for a more proactive approach to patient care and can add to the differential diagnosis, as dysphagia is more likely to occur in some types of neurologic injury than others. Completion of swallow screenings on all post-stroke patients every time using a validated screening tool is essential. If your institution uses their own internal standardized but not validated protocol, then the interpretation of the screening result lacks meaning. So for example, here we have a couple cups with some lines drawn on them. If we're guesstimating how much that we're actually giving the patient, that is not part of a standardized protocol or a validated screening. So our completion rate is only meaningful when the tool itself is validated. Some examples of validated swallow screenings include the Yale Swallow Protocol, the Toronto Bedside Swallow Screening Test, the Acute Stroke Dysphagia Screening, also known as the Barnes-Jewish Hospital Stroke Dysphagia Screen, and the Rapid Aspiration Screening for Suspected Stroke. When validated tools are used, screening results have clinical meaning. Validated swallow screenings or validated tools are standardized, they're validated, and they're reliable, meaning that each patient screened every time getting the same sort of result with the same meaning. Validated tools have known sensitivity or true positive rate and specificity or true negative rate. The sensitivity tells us that high sensitivity tells us that a test is good at ruling something out. High specificity tells us that a test is good at ruling something in. So when we're talking about swallow screenings, collaboration and training commonly between nursing and speech pathology is really key to implementing validated swallow screenings and maintaining the screening fidelity. This partnership is key to the success of a long-standing and in-place swallow screening practice. So when do we perform a swallow screening? On every patient post-stroke, prior to any attempts at oral intake, including oral medications, every time, no exceptions. So the standardized patient pathway post-stroke would include the swallow screening and the speech-language pathology consult. And the screening would be performed prior to any oral intake. So in practice, this looks like the patient coming in with acute neurologic symptoms, a stroke alert or a code stroke is activated. And when the patient is stabilized and prior to any oral intake, the screening is performed and documented. The speech pathologist is consulted. The speech pathologist is consulted regardless of the outcome, as our scope isn't limited to swallowing and swallowing disorders and includes the domains of motor speech, language, and cognitive linguistics. There are two possible outcomes for swallow screenings, and that's a fail or a pass. So if the patient fails, they are kept NPO strictly until the speech pathologist is able to see them and performs the clinical swallowing evaluation, which we'll describe in a minute. And if the patient passes, oral consistencies can be ordered by the primary team. The great thing about a swallow screening is that it can be repeated more than once. So if the patient has a rapid improvement in symptoms, so let's say they come in with a TIA, the patient can be screened again, and oral intake might be ordered for the patient if they are looking better and if they've passed. They still need to be seen by the speech pathologist if they've failed at any point. It's also helpful for patients who may have been screened initially and passed, but then have a change in their symptoms or a decline in their symptoms. And this can be implemented relatively quickly and help set off a different cascade of events for patients who need reassessment from the speech pathologist and perhaps a different plan of care. So when performing a swallow screening, just follow the instructions from the protocol. No deviations or clinical judgments should be made. So it's just that strict pass or fail. Each aspect of this swallow screening should be documented so that where the patient either passed on the pathway or fell off the pathway should be known to all members of the care team. This is especially helpful for me as a speech pathologist. I oftentimes look back and try and figure out if the patient's presentation is similar to the screening, different than the screening, or if there are other factors influencing their ability to take oral intake. We want to make sure that each aspect of the screening is documented, and the final result should be traceable to the components that resulted in either that pass or that fail. So again, 2 outcomes. Pass, the patient is initiated on a regular or easy to chew menu with thin liquids. No other alterations can be made. A fail is that the patient remains NPO pending the clinical swallowing evaluation performed by the speech pathologist. Rescreening is possible in that interim, right, until the speech pathologist can get to see them, but a failure at any time point warrants that SLP consult. So a screening is just pass or fail. And so there are no alterations to consistencies such as puree, diet, thickened liquids. There's no implementation of any strategies such as, putting your chin down towards your chest. These can have unintended consequences and are not within the outcomes of what a screening can tell us. So now we're going to switch gears and talk about what the clinical swallowing evaluation is, which is only ever performed by a speech language pathologist. So this is much more in-depth than a screening. It is not a pass-fail outcome. It includes a chart review, patient or caregiver interview. There are standard components that are included in a clinical swallowing evaluation, including a cranial nerve and intraoral assessment. Oral trials can be provided, and the overall impression from our complete evaluation helps to inform the speech pathologist's hypothesis about what might be happening in terms of swallowing physiology. But really knowing what happens with swallowing physiology is only knowable with imaging. So a clinical swallowing evaluation, there are some post-stroke risk factors that increase the likelihood of dysphagia that are listed here. We also then have some clinical factors that help to identify patients who might be more at risk. And so these are the things that will come out of our clinical exam, like an unstable respiratory status, indication for cranial nerve impairment, aphasia, a lower maximum phonation time, impaired voluntary cough testing. And then general risk factors that we know are risk factors for aspiration and dysphagia across all patient populations, including advanced age, cognitive impairment, feeding dependent, and then abnormal frailty indices, which also includes living in an institutional setting or some standardized scales, including something like the Apache 2, if it's an ICU setting, or the Charlson Comorbidity Index. The clinical swallow exam is evaluation is a physical exam and can be used to determine the patients who should be prioritized for oral intake versus those who need to have swallow imaging prior to making recommendations for oral intake. The clinical swallow evaluation does provide diagnostic information. Again, it goes back to that hypothesis that the speech pathologist will formulate about the type, the nature, the potential etiology of the suspected impairment. But because it's a clinical exam, it of course has limits. There are only certain aspects of oral physiology, very limited aspects of pharyngeal physiology, and almost no aspects of laryngeal physiology that are knowable from a physical exam, such as the clinical swallowing evaluation. Imaging is absolutely needed to determine the dysphagia type, such as oral pharyngeal, pharyngoesophageal, and severity, such as mild, moderate, severe. Those are unknowable without imaging. And so I'll turn it over to my colleague, Dr. Brittany Krickler.
Thank you, Dr. Reedy. I'm going to go back here for just a second and do a quick housekeeping to please put questions in the chat if you have, or in the question and answer feature at the bottom of your Zoom screen if you have questions. So go ahead and use that instead of the chat. Thank you so much for having me. I'm thrilled to be here. I'm Brittany Kreckler. I'm an associate professor in otolaryngology at the University of Cincinnati, and I'm going to be talking about swallowing imaging in the subacute care timeframe. We're going to focus on why it matters, when we should be thinking about it, and how the stroke team in general can help support access. So you've heard us now using this term swallow imaging several times throughout this talk. When I say swallow imaging, I'm mainly referring to two types of evaluations: modified barium swallow study, called MBSS, also called video fluoroscopic swallow study, VFSS. We use these terms interchangeably depending on your institution, and flexible endoscopic evaluation of swallowing, or FEES. Both of these evaluations allow us to move beyond what we can observe at the bedside alone, as Dr. Reedy was just indicating, to get that knowable information from the imaging studies. I'm going to play these videos for you so you can see what these evaluations look like in real time. Modified barium swallow studies use video fluoroscopy while the patient swallows modified barium containing foods and liquids. FEES uses a flexible endoscope passed through the nose to view the pharynx and larynx during swallowing. In FEES, foods and liquids are typically dyed to improve visibility. So you can see here, these foods and liquids are dyed blue, and it helps you see the difference between the food or liquid and the secretions that the patient has at baseline. You can see the modified barium swallow study again happens really fast in a normal patient. So these two studies give us two different views. Modified barium swallow study provides a dynamic radiographic view of bolus flow, airway protection, and movement of the bolus through the oral cavity, pharynx, and upper esophageal region. FEES presents a close endoscopic view of the pharynx and larynx, including secretion management, airway protection before and after the swallow. So one terminology point I want to emphasize is these are not tests. These are swallow studies or evaluations. They're not pass or fail. Patients are often asked whether they pass their swallow test, but this framing can be demoralizing and misrepresents the purpose of the evaluation. A patient can't fail an MRI. They can also not fail a swallow study. The goal is to understand what's happening and how to support safe and effective care for that patient. So why do we need swallow imaging? The simplest reason is we don't have x-ray vision yet. If someone can come up with that, it would probably save us all a lot of headache, time, and money. But right now we don't have it. So while the bedside evaluation is important, like Dr. Reedy mentioned, it gives us a lot of contextual information about the patient. It cannot directly show us what's happening inside the pharynx or upper esophagus. We would not treat a stroke without CT or MRI because imaging helps us define the problem. Dysphagia care is exactly the same. Imaging helps us define the swallowing impairment so management can be targeted and make sure it's not harmful. So our question here with imaging is not only whether the patient aspirates or has residue, but why aspiration and residue is happening. So the imaging allows us to answer this question. Is it timing? Is it reduced airway closure? Is it reduced pharyngeal contraction and clearance? Imaging lets us see the aspiration and residue events in real time and identifying those mechanisms that underlie those impairments. So that's what we can treat. So when do we get imaging? So Dr. Reedy just brought us through the screening failure, what the clinical swallow evaluation involves, and that's really where the SLP is making that decision whether or not imaging is needed, and then which modality is most appropriate to use first. Sorry, my slides are jumping around a bit. So who needs swallowing imaging? What is the SLP thinking about when they're making this decision? So we're thinking about looking at the evidence regarding our screening exams first off. So as Dr. Reedy discussed, validated swallow screens are both sensitive and specific. So data show that 70 to 90% of patients that fail a bedside swallow screen who have had a stroke will have documentable dysphagia when you take them and look at them under imaging. So that means these screenings, if they're valid, are identifying true dysphagia 70 to 90% of the time. That's a really high rate of accurate assessment. So validated screens help us identify risk and potential presence, but they don't replace imaging. So another issue that we see with post-stroke dysphagia is that oftentimes these impairments will present silently. That means we're not able to detect them at the bedside. So they might fail that swallow screen, but they aren't coughing, they aren't throat clearing, they look perfectly fine at the bedside. Data show that nearly 70% of patients with post-stroke dysphagia are actually presenting with silent aspiration when you look at them under imaging. That's a huge number. So this is sort of a visual example of what silent dysphagia after stroke might look like. You give that person a sip of water or a bite of food at the bedside. They look completely normal on the surface. No coughing, no throat clearing. Their vocal quality sounds normal. These are all signs and symptoms that we look for as potential indicators of dysphagia. But these patients oftentimes show nothing. So when we're relying on bedside observation alone, these are the patients that we're at risk of missing, and there's a lot of them. So silent dysphagia after stroke is common because the neurologic injury of the stroke can affect sensation, cognition, and communication. So patients may not be feeling the aspiration, they may not recognize the swallowing issues they're having, or they may not be able to clearly report their symptoms due to a communication issue. Imaging helps us identify those impairments that are otherwise under-recognized, and especially for those patients who are moving into that subacute recovery phase. If we miss those impairments, like Dr. Bonilla was mentioning, we're missing the opportunity to give them services to code that in the chart and make sure they get that follow-up care to reduce their pneumonia risk, dehydration, malnutrition, and quality of life in that discharge space. So the main issue is that plagues us daily in the clinic is that swallowing imaging is unfortunately a limited resource. So FEES and modified barium swallow study both require equipment, training, personnel. For modified barium swallow study, transportation, and coordination. So in many hospitals, the need for imaging exceeds the available staff and time or imaging capacity. So not only stroke patients are on an acute SLP caseload, right? There's lots of other patients that are in for other procedures and other reasons that also might need imaging of their swallowing. So this becomes a resource issue and a bottleneck problem. This limitation in availability does not mean that this is an optional evaluation. Imaging is essential because we worry about those patients that we may miss that are not showing obvious signs at the bedside. So one consequence of not imaging a patient is that we may over-rely on generic modifications. So many people have heard this or even use this themselves. Well, if we're worried they're aspirating, let's just thicken the liquid. We know that maybe helps with aspiration in some patients. But unfortunately, thicker does not mean safer. So if a patient aspirates a thicker liquid, as shown in this example here, the patient's not aspirating thin liquid, but they do aspirate on the thicker liquid, it's actually harder for the lungs to clear that liquid if it's thicker. And we have data that show that thickened liquids, when aspirated, do increase the risk of respiratory complications. So we need imaging to identify whether this modification is actually going to be helpful to this patient and not harmful. And we're not able to see that at the bedside. The same is true for postural strategies like a chin tuck. So if you can see in this example, when the patient tucks their chin, actually we're getting spillage from the piriform sinus into the airway. So the chin tuck is actually not working for this patient. It's actually making them aspirate, whereas when they swallow with their head in the upright position, they're not aspirating. Sorry, my slides are advancing before I'm ready. So imaging helps us, again, test whether that strategy or that modification is actually helping that patient and safe and not making things worse. So we get this question a lot from the team. Should we get FEES for this patient or a swallow study in radiology? So my answer is that both of these are essential tools in post-stroke dysphagia care, and it's really the job of the SLP after that clinical swallow evaluation to decide which modality to use first and at what time. These are complementary assessments, not interchangeable. I'm going to say that again. These are complementary assessments. They are not interchangeable. So if a patient gets a FEES, that doesn't mean check the box. They're done with their imaging, they're out. We sometimes need FEES, we sometimes need MBS, and I'm going to talk a little bit about the difference and why we use these tools differently. So FEES is particularly useful early on in that stroke timeframe when there's concerns about secretion management, whether or not they're safe to even begin trying to do bolus trials, if they're even ready for a modified barium swallow study. We use this evaluation if we're concerned that there's a vocal fold pathology or paralysis or vagal nerve injury. FEES is also helpful for that early decision-making around oral intake safety, so medication administration and whether short-term enteral access may be needed. We can bring this to the bedside in the ICU. SLPs usually have a little bit more timing and control over when these FEES are occurring because the equipment's usually in their department. Modified barium swallow studies, on the other hand, are necessary for seeing that bolus flow through the oral pharynx and upper esophagus. So without modified barium swallow study, the treating therapist in that acute or subacute rehab setting won't have the information they need to understand the mechanism of dysphagia. So it's especially important to get this MBS done before the patient discharges. This helps us identify those specific timing or structural impairments that can be targeted during early rehab. So these are both essential imaging modalities. Oh, just in case you forgot, one more time at the bottom. We need them both. We can't just have one and we can't just have the other. So this is just an example of where fees might be useful early on in that time course. This is the same patient with fees done within a week. And you can see at the very beginning of the modified barium swallow study, you're not able to see those secretions, but we're able to see that clearly on fees. So this becomes a really important assessment tool, again, early on in that stroke pathway when we're trying to decide if that person is ready for oral trials. So if imaging is this important, and hopefully I've convinced you of that by now, why is accessing it so difficult? What are the issues? So the barriers are often very practical and system-based. It's equipment availability, it's radiology scheduling, it's fee scheduling, it's completing these procedures, it's staffing both for the SLP side and the technologist side in radiology, transport logistics, time constraints, and differences in training and standardization competencies per institution. So these are not just SLP issues, they're system level issues. So it's going to take a team approach to improve access to these modalities. So one thing I like to point out that I think is really under visualized in this space is the reimbursement issue. So this is one major systems level issue. Medicare fee schedules are currently undervaluing the SLP component of modified barium swallow study relative to the procedural demands. So the modified barium swallow or VFSS code is reimbursed at only a slightly higher dollar amount than that clinical swallow evaluation that doesn't require any equipment, any transport, any radiology coordination. And fees is reimbursed at a substantially higher rate. So these mismatches we're seeing this happen in real time, are influencing staffing models, institutional priorities, and capacity. As you can imagine, there's prioritization of a procedure that has a higher reimbursement rate, even though the other exam is what's actually needed for that patient. So I just like to bring awareness to this issue, and we're actively working on it, but it's a slow change. So there's also a discharge issue. So once the patient discharges from the acute care setting, we're seeing access to swallow imaging drop significantly, especially for modified barium swallow study. So getting these evaluations is often easiest when the patient is still admitted in acute care. So after discharge, we're seeing access to these instrumental or imaging swallowing exams become delayed, inconsistent, or sometimes unavailable. So in our work, we've actually seen 16% of patients in skilled nursing facilities waiting more than a month for a modified barium swallow study. So that's a very long time in that subacute time frame when we're trying to get that patient in rehab. We don't have information about what we're supposed to be targeting in therapy. We're losing that critical recovery window when aspiration risk is high, nutrition and dehydration risks are high, and therapy planning really matters. So imaging before discharge can help send patients to rehab or home with better diagnostic information to have better targeted treatment goals in that subacute, really important time frame. So advocacy is a team sport. Everybody plays a role. Just to kind of echo what Dr. Benia said, neurologists can support time for swallowing workup before discharge and help push back on those discharge pressure timeframes when clinically appropriate. Nurses can ensure validated screening tools are used and that they're following those protocols so we're not missing those patients that Heather pointed out in her portion of the presentation. We're clearly missing some of these patients without using those validated screening tools. And then the nurses can kind of push for that trigger for swallow evaluation by the SLP. And then dietitians can help connect swallowing imaging results to nutrition, hydration, and discharge planning to kind of loop that back into the care team and really help that patient understand why those modifications are happening to their diet. So the bigger point is that timely swallow imaging is a part of stroke care that really is a team sport and requires that support and advocacy from the whole team. So with that, I'm going to hand it off to Caitlin, and I appreciate your time.
Thank you. I'm really excited to talk about this topic. This is one of my biggest passions in as my role as a speech therapist and in dysphagia care. So we think about our patients through that whole pathway. They've had a validated swallow screening completed. A speech therapist has seen them at bedside. We've done imaging, and now we know what's going on and they're aspirating. Now we wonder what's their risk of aspiration pneumonia, and how can we help control and prevent that. See if it'll let me advance here. There we go. So what is pneumonia? Pneumonia is an infection in our lungs. Our lungs are filled with alveoli, which are air sacs. And when we have an infection like pneumonia, those can fill with pus and fluids and make it hard to breathe. And you have to clear secretions and clear that out of your airway. This can be caused by things like bacteria, viruses, fungi, and aspiration. Common symptoms. So if your patient has pneumonia, they may have some, but maybe not all of these symptoms. So a cough, chest pain, especially when they're breathing, fever and chills, GI changes, so diarrhea, nausea, vomiting, fatigue, and shortness of breath. And then our patients, typically 70 and older, may have altered mental status that isn't otherwise explained. So the CDC does have some guidelines that I've linked here. So when you are able to access these slides, you'll be able to click on that link that'll take you to CDC guidelines. But diagnostic criteria come from physical exams. So looking at those symptoms we just talked about, the altered mental status, fever, do they have dyspnea? Are they tachypnic? Are they breathing really quickly, like 25 breaths a minute or more? Again, not otherwise explained by activity. Do they have increased oxygen needs, different from their baseline? Do they need a nasal cannula, high flow, BiPAP? Do their vent settings need to be changed? Lung sounds, sputum cultures, looking at their labs like high or low white blood cell counts. And then we just talked about swallow imaging, but imaging is also important in diagnosing pneumonia. So a chest x-ray or chest CT to look for infiltrates, consolidations, cavitations. So aspiration pneumonia is a type of pneumonia that's caused by the inhalation of something other than air. So it could be food or liquid, your saliva, stomach contents from reflux or emesis, and other foreign material. You might have heard this in your practice before. Your speech therapist might talk about it. You might have heard it somewhere else, but we talk about the pillars of aspiration pneumonia. So these three conditions really need to be met simultaneously in order for a pneumonia by aspiration to occur. So a patient needs to have a compromised immune system. Aspiration needs to be occurring, and they need to have an impaired oral health status. I love this chart. I use this a lot with my patients and families and with staff that I work with. It really helps emphasize that these three pillars and how they can impact our patients. So we're looking at these three conditions: oral health status, laryngeal valve integrity, so are they aspirating or not, which we would know from our imaging, and then their immune system status. Studies show that stroke can result in systemic immunodepression. So our patients may be in this borderline of they might have a reduced immune system. They might be compromised for other reasons too. So they may be in this rows 5 through 8. Now, let's say we've done our formal assessments and we've done imaging and we see that our patient's aspirating. Now we're looking at rows 7 and 8. So if our patients have good oral health status, even if they're aspirating and even if they have an impaired immune system, they're actually at a low risk of getting a pneumonia. Now, if they have poor oral health status and their mouth is full of bacteria, and that goes along with their aspiration down into their lungs, and they have an impaired immune system, they're at a high risk of getting a pneumonia. So it shows us that oral health status is really important in determining that risk of getting an aspiration pneumonia, and that's something that we have more control over. This is a staggering number. I know we've seen a lot of other numbers and statistics in here, but over $27,000 is the marginal cost of pneumonia on the hospitalization of one stroke patient. So if your stroke patient gets pneumonia, it's going to cost the healthcare system $27,000 more dollars. Again, oral care is something we can control and we can reduce this number. I'll caveat this number might be higher than what's displayed here. I know Dr. Vanilla talked a lot about misdiagnosis and miscoding, and that can change, again, how these numbers are obtained. There's some other factors that can increase the risk of aspiration pneumonia: dependence for feeding and oral care. If our patients are dependent for oral care, they're less likely to receive it or receive it as properly as if they were able to do it themselves. Dependence for feeding can it changed that pre-oral phase and the cognitive kind of phase of swallowing before food even gets to our mouth. So when someone's feeding you, it changes the way that we eat. Tube feeding, smoking, and number of medications can also increase these risks. Let's talk about oral health. I like to think of our mouth and our nose as kind of this like bus terminal train station gateway to our body. There's so much is coming in and so much is coming out all day long. We breathe, we eat, we lick our finger before we count money, and then we lick it again. There's a lot of stuff that's coming in and out of our mouths constantly, and it's a complex system. I love this quote. It's the second largest reservoir of microbes in the human body after the gut. That's incredible. And I don't even think they've identified all of the microbes that are in our mouth. So it's really important. And changes to our oral cavity and our oral microbiome can cause systematic damage to our bodies. So in comes the protective role of saliva. I like to think of, if we're thinking of our bus terminal or train station, that saliva is like our head of security or our security system. And there's a lot of roles that saliva plays in our mouth. It's a lubricant and physical shield, so it keeps things moist. It supports swallowing. It's really hard to swallow. If you wake up in the morning after a cold and you breathe through your mouth all night, if you try to swallow, it's near impossible, and it hurts and it's painful. We don't have that lubrication because we're really dry. It acts as a chemical buffer and neutralizes acids to maintain an optimal pH in our oral cavity. It has antimicrobial properties to kill or inhibit pathogens. It helps heal wounds. So wound healing can be quicker in our mouth because of saliva. And it digests. So there's enzymes like amylase that can break down food before we even swallow it, before it even gets to our stomach. So there are several factors that can promote colonization of bacteria in our respiratory system. And I'll say a lot of these kind of home back into xerostomia, which would be dry mouth. If someone has open mouth posture when they're just awake or sleeping, it can lead to dry mouth. Lack of appropriate oral care can lead to dry mouth. NPO status can lead to dry mouth. So again, it shows you the importance of the protective abilities of our saliva. We talked about dependency, and people who are bedridden as well can impact that. Risk factors for poor oral health. As I mentioned before, disabled adults are more likely than the general population to have unmet oral health care needs. When you're dependent for it, and it's not someone's priority, it's not going to get done as frequently as it needs to. It's not going to get done as well as it might need to. So risk factors for poor oral health are higher NIH scores, neurological diseases, reduced alertness, poor secretion management, dysphagia. So quick trigger warning, I will show you some real oral healthcare pictures here. So if you're eating something, maybe stop for the next second. I won't linger on it too long. So this is a patient, a man. We can see he may have open mouth posture. He also might just be opening his mouth for an exam, but let's say he has open mouth posture, so he may be more likely to have a dry mouth. It looks like he has an NG tube or Dobhoff tube that you can see in the corner of the picture. His lips look dry and cracked. They're dried, caked on cemented secretions or mucus or food in his mouth. So imagine yourself in this position and try to imagine what it would feel like to try to swallow, or if someone gave you a sip of water. That would be really difficult. And so a lot of oral care needs to happen here. So I'll show you after pictures in a bit, but I'll move on so you don't have to linger on that too long. Oral care is infection prevention. So just like we wash our hands after we go to the bathroom to prevent infections, just like we wear protective equipment and have special cleaning procedures for our contact and tear precautions to prevent infections, oral care prevents infections. And we should have a systematic way to provide oral care for our patients. Many people treat it, and even patients, not just staff, treat this as a comfort, right? It's low priority. I'll brush my teeth later. It's fine. I've got to worry about these other things. And that's not the way it should be viewed. Simple oral routine procedures and care can reduce the incidence of pneumonia. Excuse me. Oops. All right, so the outcomes of good oral care. It can improve our oral intake and decrease malnutrition, right? So again, we have better saliva production. If patients have good oral care, they're more likely to eat more. It can improve overall patient health outcomes, preventing tooth decay, reduce bacteria in the mouth and pharynx, and then improve breath, which is always nice for the patients. It's nice for their families that want to get close to them. And it's always nice for us as staff who work really nice and close with our patients. We want them to have nice, fresh, minty breath as well. Here's a quick after of our patient I showed you earlier. You can see his lips look more moist. The hard palate in his mouth, so at the roof of his mouth, looks moister. All of that caked on secretion is gone. There's still some secretions that are on his teeth that look a little dried, so there's work to do, but this is a huge improvement, and he's probably more likely to be able to better participate in dysphagia treatment and care when his mouth looks like this versus what we saw before. The CDC does have pneumonia prevention guidelines that include care components that have oral and nasal hygiene as a care component of their bundles, including dysphagia diagnosis, treatment, bed positioning, mobilization, sedation restrictions, and incentive spirometry. In order to implement these, you have to have a systematic way that you implement this into your system. That includes education and training for your staff, included in bundles. Oral care should be included in a bundle and documented that it's happening every day, not just a check mark on the whiteboard, but documented in the patient's chart that oral care was completed, what tools were used, what did the patient's mouth look like before or after. Engage with the family. They're probably going to be the ones who are helping the patient do oral care if they're going home. Make sure they understand how to do it, what tools they need, and include external prompts for the patients and families. Reminder, our patients who are edentulous or have limited dentition need oral care too. I saw a patient this weekend and I said, how often do you brush your teeth? And she goes, not really often. I don't really have any teeth to brush, because she looked like the guy on the top and just has one little post of a tooth there. Just because you don't have teeth does not mean that there's not places for bacteria to harbor in your mouth, in your gums, on your tongue, in your cheeks. They need oral care as well. Who's responsible? I know we've talked a lot about team approaches and all of this, and it's not because we're trying to be cheesy. It's true. Healthcare is a team approach, and that includes oral care. Physicians and APPs need to be our stewards for oral care practices. Ensure that those are in your order sets. Ensure that this is happening for our patients. Is it part of our admission intake, asking the patients what oral care looks like for them? Our speech and occupational therapists might be doing oral care with our patients in our sessions, finding ways to adapt the equipment, finding ways to help train the patients and families. Patients, families, and caregivers are participating in that. Our respiratory therapists might be involved, especially with our vented patients, and helping provide oral care. And then nursing staff, our nurses, our PCTs, and patient technicians. You guys are there hands-on all day, every day, and might be more frequently providing oral care or looking in the patient's mouth or reminding the patients to do oral care for themselves if they're independent. So what do you need? These are some supplies. I don't endorse any specific products. These are just ones that I've used and seen before. I'll walk through some steps in a second, so I won't go through all of these. Make sure you protect yourself first and foremost. So wear a mask, eye protection if you can. Things can fly out, or patient can cough right when you're in front of them. So make sure you protect yourself. Use a light if you need to, and find the products that you need at your facility when you go into the patient's room. So oral care plans, make sure your patients, if they're able to participate in oral care, have adaptive equipment for them. That might be a built-up handle or a wristband or handband to put on the toothbrush or suction equipment. Help them incorporate it into their routines, reminders and checklists for the patients in the rooms, and again, that education piece. If your patient is dependent for oral care, here are some steps you can follow. Make sure they're upright as much as they can be comfortably, or side lying. Inspect their oral cavity. So use your pen light or a tongue depressor, see what's going on in there. You can use a suction or swabs to remove any debris or pooled saliva. Swabs are not a replacement for a toothbrush. You should only be using them as needed, and they are great for helping remove caked on secretions or food particles left in a patient's mouth, but you still need to use a toothbrush if that's appropriate for your patients. Make sure you brush their teeth, gums, and tongue. Use a soft or a suction toothbrush. Be gentle, especially those patients with really caked on secretions. You don't want to rip those off and cause unnecessary bleeding, especially if they're on any kind of a medication that can make them bleed more. So be really soft and gentle. It might take several sessions to get some of that material out of their mouth. If they have dentures, remove them, clean them with whatever appropriate tools that you have for that. Help them rinse their mouth using a suction or swabs if you need to. You can apply a mouthwash with a swab. And then use mouth moisturizer. There's gels, there's Biotene, there's Xylamelts, there's all sorts of equipment that and tools that you can use to help patients keep their mouth moist if it's appropriate. And then lip balm to keep their lips moist as well. And again, that thread that goes through education and train. So educate your patients and families, train them on how to do it. So now your patient has a clean mouth. We know they might be aspirating. Maybe we've made some recommendations for some diet changes. What do we do now? Well, there is something called the Fraser-free water protocol. And this is a protocol that's designed to allow patients to have thin water or ice chips, despite knowing that they aspirate thin liquids. So we've done imaging. We see that they aspirate but this is a protocol that allows them to still have water. Water's safer. It contains less pathogenic bacteria, and it can be absorbed more safely into our lungs. I know we talked earlier, Brittany mentioned that thickened liquids are harder to expel from our lungs. Thin liquids like water can pass that blood gas exchange better in our lungs. So water can be pretty benign and harmless if our mouth is clean. So when patients are on these protocols, it can help them increase their fluid intake, reduce xerostomia. So again, keep their mouth nice and comfortable. It can improve their oral health and swallow function, and they can have better compliance with their dysphagia plan. So if they're on recommended thickened liquids, they might not enjoy it. But if they're allowed to have these moments where they can have thin water and ice chips, they can have better compliance with those thickened liquids that were recommended. And I think all importantly, the patient satisfaction and quality of life improves when they're able to have thin water and ice chips. So some criteria to consider. This is for patients who are NPO or on thickened liquids. I will caveat if they're NPO for their dysphagia. So if they're NPO for GI or surgical reasons, please check in with those providers to make sure that you are not implementing a protocol that goes against some other medical conditions that the patient has. So be mindful of that and check in with them. Make sure your patients are able to swallow thin water without excessive coughing. Now, this is subjective to your patient. Some patients might take a sip and cough a little bit. And if that's fine and it's not distressing to them, then that's okay. It's about their comfort, not our comfort as a clinician. Obviously, I think there are some times when excessive coughing can be the patient's getting red in the face and their O2 sats are dropping, and then that's an instance where we might say this is excessive and this might not be appropriate at this time. Make sure they have appropriate mental status, or they're awake and alert enough and can maintain upright posture as able. If they have fragile pulmonary disorders, or if they have dental or oral infections like thrush, make sure those are resolved before you implement this kind of protocol. Some implementation kind of rules. These should be recommended only by a speech therapist after they've completed their formal assessment and imaging. The patients should wait 30 minutes after meals or eating anything else that's not the thin liquid or water. Oral care needs to be completed before they have ice chips or thin water, and they cannot have anything else during that time. So no other food or drink, no medications with thin water. Make sure you educate your staff, educate your family, and document this and post head of bed signs or give the patients information. Make sure everyone is aware of what this protocol is and how to implement it. This is just a quick example morning routine timeline for someone who might be on the protocol. So let's say they wake up at 7 a.m., they brush their teeth. Now they can have their thin water and ice chips, and they do that for a bit of time. Now the nurse comes in with medications at 8:30. They cannot have any more thin water or ice. They get their medications however recommended. Breakfast comes and they get their thickened orange juice and their thickened coffee. Now they want ice and water again. They wait 30 minutes, and then at 9:30 they brush their teeth again, and then they can have their ice chips and water. So it's really these isolated times that they're able to have thin water and ice chips after they have had oral care or brush their teeth. Successful implementation. This can work. It just means that we need to have good education to our patients, to our team, to our staff. Shared decision making needs to happen. When we make recommendations, we ask the patient what their goals are. If their goal is to not ever aspirate anything, what does that look like? If their goal is, well, I'm okay with some risk and I want to implement this water protocol, what does that look like for you? If their goal is, I want to eat and drink whatever I want, but try to be as safe as possible, what can we make that look like? Make sure you have order sets, templates, documentation, and signs. I have some examples we can talk about at another time, but I will save some time here for Yanita to talk about our next section, and I will give you control here if I can find my mouse. Okay.
All right. Can everybody hear me? Perfect. So I am excited to finish up our presentation before we go into the Q&A. And I looked a little bit at some common questions in the chat, and I will try to address some actually during my presentation. So when we talk about oral intake or diet modifications, we can group them within compensatory strategies. So like with any other stroke impairments, we have two main ways to address or to treat disorders. Rehabilitation strategies have the goal to restore function. Compensatory strategies have the goal to increase or improve safety efficiency in the moment they are applied. As soon as they are taken away, that would not be the case anymore. And we traditionally believe that oral diet intake modifications fall under compensatory strategies. Again, emphasizing that this should only be temporary. Nutrition is really important, especially after acute stroke. So malnutrition is very common in this population that we see. And to make things even worse, malnutrition actually declines within the acute hospital stay, or there is a risk that it declines. Due to multiple reasons, right? So while we all recognize that how important nutrition is, the reality is that it can be quite challenging to provide acute stroke patients with the nutrition they need. And this might be because they have dysphagia, what's the topic of our conversation here today, or they might be waiting for specific procedures where they have unfortunately prolonged NPO periods, or they repeatedly pull their feeding tubes, etc. So there are some challenges to that. But I think what we need to keep in mind is that nutrition has an immediate impact on recovery and also long-term impacts on recovery. So, and this is, I think, really an interdisciplinary focus topic. So while as SLPs, we might think about, is it safe? Is it okay for a patient to take anything by mouth? Any other healthcare member on the team has very distinct contributions. And one of my pet peeves is when and I can tell you, I did this as well many, many years ago, when speech language pathologists do an assessment, if it's a bedside assessment or an imaging assessment, and then recommend NPO except meds. So if we have concern about the safety of intake as speech language pathologists, I'm very curious why we think that medications then will not travel down the wrong path. So there are a few instances where I believe that the recommendation NPO except meds makes sense, but only if the entire team actually contributed to that decision. So I saw recently a patient who unfortunately had a cancer diagnosis and had to take a chemo drugs PO, and they could not be changed by the pharmacist to anything else than that. I provided my impression of is it safe or not safe to take anything PO. The doctor ultimately, though, the physician ultimately made the decision, what is more risky, the aspiration or missing those drugs that can't be given in any other way than PO? So again, this is, I think, an example where only the interdisciplinary team can make those decisions. For post-stroke dysphagia, one of our biggest questions is then to feed or not to feed, right? So we have some options to go. We can either say, yep, the patient can take by mouth nutrition in regular consistencies, or we can modify consistencies. NPO is an option where we might hope and wait, or we decide for alternative means of nutrition, or a combination of those might be what we decide. Interestingly, historically, especially in the research arena of dysphagia and speech language pathology, we tend to equate aspiration with adverse events. And that now, with new evidence, has challenged our thinking that we should restrict people who aspirate with oral intake. So while we traditionally have focused dysphagia management heavily on preventing aspiration, we now know aspiration does not equal pneumonia. And the real question instead should be whether the patient has the physiological reserve and airway defense to tolerate that aspiration. And again, to answer this question, the entire team is needed, right? So it's not that if a patient is aspirating, as if the host, the patient, has the capability to defend. And one aspect that comes into play is what Caitlin presented is oral care and oral health as well. So if we provide or the recommendation for diet modifications, It's important that we speak the same language so that if a patient would be transferred to a different institution or even just transferred within the hospital to another unit, we still provide the same consistencies prepared in a standardized way. And the most popular, most well-adopted framework is the ITSI framework. This is the pyramid that you see here on the right, the International Dysphagia Diet Standardization Initiative. And this is actually a framework that's internationally adopted. And that gives guidance on how we measure specific consistency and which terms we should use. Again, it is a compensatory mechanism when we think about diet modifications, and it should only be ideally temporarily, what necessitates reassessments if we provide recommendations like NPO because of dysphagia. It's also that we should think about if we provide this recommendation of NPO, we need to be mindful of how this might impact neural recovery. One of the neuroplastic principles, use it or lose it, might then make us think about if we restrict a patient with swallowing, this will also impact the likelihood of recovery. So again, I think we brought this point home. Thickened liquids is not the cure for all. And from my clinical experience, it's always fascinating to me that there is kind of a disconnect between what we might see clinically at the bedside and then with imaging. So just because a patient is not coughing when they drink thickened liquids and is coughing with thin liquids does not mean that thickened liquids are actually safer. We have specific receptors in the larynx that specifically respond to thin liquids, but do not respond to anything thicker. So you might then provide a patient with thickened liquids, even though they still aspirate and don't even cough. So again, imaging is really important here. So feeding tubes, right? If a patient has dysphagia, does not meet the nutritional needs PO, feeding tubes are very important and are widely used. But I think we need to remember that even if we provide a feeding tube due to fear of aspiration with PO intake, we know feeding tubes do not eliminate aspiration and not eliminate the subsequent risk for adverse events like pneumonia. NG tubes, it's a love and a hate relationship, I think, for every clinician. They carry their own risks, right? And then also we run into ethical questions if a patient continuously pulls the feeding tube, what then might come to discussions of restraints, and that, of course, can have their own impacts on recovery. G-tubes, gastrostomy tubes, very important instrument. However, they also have their complications, well-documented complications. We did a study where we looked at thousands of patients due to billing data, and we found at stroke patients, 20% of those that were discharged with a G-tube were actually readmitted within 30 days. And one of the main reasons was aspiration pneumonia. So it's not the cure for all. What should we do? So yes, there are some practice guidelines that can help us a little bit in the decision making. NG tube, G tube, what time? American Heart Association, American Stroke Association repeatedly implemented the guidelines that G tube placement should be considered for patients with longer anticipated persistent inability to swallow and should be placed not within the first 2 weeks. And that's mirrored by other guidelines as well. So where does this evidence come from? There are several clinical trials that looked at the timing of G-tube placement. One of the most popular and the biggest clinical trial addressing this topic is the food trial that was published now over 20 years ago by Martin Dennis and colleagues. And 2 of those 3 trials that they did pertained to the question of feeding tube placements in acute stroke. For trial 2, they enrolled dysphagic patients within 7 days of admission, and then they were allocated either early or avoid any enteral tube feeding for at least 1 week. Those patients that were randomized to the avoid group, they were allowed to take nutrition by any means except by a tube. So they could eat orally, they could have an IV, etc. Over 800 patients were enrolled across 15 countries. And then dysphagic patients in the third trial were allocated within 30 days of admission to a feeding tube, either by G-tube or nasogastric tube. And typically in this trial, within the first or second week, the tube was placed. Over 300 patients were randomized, again, across the world. So main findings from this trial. They found that better functional outcomes and survival was observed for early versus late tube feeding. And they measured the outcome, this is important, 6 months after the original admission for that stroke. So it's long-term outcomes. When they then broke it down, okay, when we place an NG tube or G tube early, they found that those that had first or early on the NG tube tube feeding had better functional outcomes. They further found that more G-tubes compared to NG-tube feeding required tube feeding at follow-up. And survivors in the G-tube group had actually a lower quality of life. Again, this was all measured 6 months after. So the authors concluded that their results actually do not support a policy of early initiation of G-tube feeding. I just want to mention that there are also some methodological concerns with this study. They did not reach their recruitment goal, so just only half of what they actually attempted to recruit. So just keep that in mind. So some newer studies mirror what was found by Dennis et al. And I think there are two camps of those publications that we have so far. One camp looks just at the acute care, and then other publications also look at what happens after acute care. One example for the acute care evidence comes from Reddy et al. They found that early G-tube placement did not result in increased mortality or complication, but decreased length of stay. So they recommended, well, let's tend to do the early G-tube placements because that will reduce length of stay and will save costs. So I want to caution I really want to caution to use this evidence. We're not also considering the long-term outcomes. So a study by Bomena et al., and there are others that reiterate that as well. When they look at later outcomes, they found that actually late G-tube placement increased the odds of swallow recovery, and mortality complications were the same. So we need to think, why is that? Likely because literally an NG tube is in our face as healthcare providers, and we have a higher incentive to do something about it. So the perception that an NG tube is temporary is much higher than a G tube that we might unconsciously perceive as permanent and then provide different healthcare services. So again, our emphasis today is we need to reassess those patients, even if they had a G-tube, because that also should be ideally a temporary solution. All right, so unfortunately, even knowing all this evidence, we still find ourselves in the dilemma of guidelines and reality often not confirming. So the typical stroke patient is discharged way, way earlier than 2 weeks. And we are following guidelines, encouraged to observe for 2 weeks if swallow recovery occurs or not. And so there are, I think, some responsibilities that the acute care team feels that they have to make the decision of placing a G-tube or not. However, I want to challenge this thinking, and emerging exciting evidence actually can help us argue that selected patients, if we as a team come together and can identify patients with a high likelihood of recovering, can safely be discharged to rehabilitation facilities or other facilities with an NG tube in place. One study, a prospective study from Turner and Johnson, was relatively small with 20 patients, and they found those were then, those were discharged to a rehabilitation facility with an NG tube. Only 15% of these patients ultimately received a G tube. Another recent study by Robin Brown and colleagues, published in 2024, is similarly encouraging. So they did a very large retrospective study of over 400 adults with post-stroke dysphagia and showed that it's feasible to discharge patients from acute care to rehabilitation units and reducing the rate of ultimately placed G-tubes. And if that hasn't convinced you just yet, here's some really exciting but also concerning evidence that if we go into skilled nursing facilities and assess patients with swallow imaging, the majority of residents who are on non-oral diets, so on feeding tubes, actually do not need the tube. So the vast majority of patients were found to not even be dysphagic and having a G-tube that they didn't need. So to quick summary before we go into our Q&A, nutrition matters. However, we as a team, we need to balance priorities and risk and benefits, right? Aspiration does not equal pneumonia. We need to understand the host, the patient itself, to then be able to individualize strategies. Ongoing reassessment is really key. And we know that NG tubes, G tubes do not prevent aspiration, do not prevent pneumonia. However, there is some evidence that the timing of placing a G-tube might matter in terms of who we support better in recovery. And with that, I want to end here, and I think we are excited for the Q&A.
Great. Thank you, everyone. We have some great questions in the Q&A chat, and what we will do is we'll kind of consolidate into the hot topics that we have been seeing come through. I think a lot of them have been answered individually in the Q&A chat box, but I will turn it over to Dr. Vanilla.
Thank you. So excited. Thank you all for joining us on this webinar and engaging with us in the Q&A. If you still have questions, feel free to put them in and we will answer them either live or in that chat. I'm going to try to get us kind of one question each that has been brewing in the chat, and I think we're gonna I'll start with my section, really just the idea that one quick-ish thing that we can be doing is getting that diagnostic code into the charts before discharge. So that would be the big question takeaway. And somebody asked, how have I done that before? And the main thing that I have done, besides a lot of education and re-education, has been to befriend my stroke coordinator and the people who sit around that discharge planning table. And those are all super big advocates, and we can all check each other and say, hey, this patient's going out. Ooh, do they have, we checked OT, PT, SLP, all the things. And oh, do they have the coding? Are they getting what is going with them? What are those pieces of paper? What are the swallow eval information, the documentation that needs to go to the next setting? So that's really a great place and great people around the table where there's many of us. Even if the SLP is not the one who's sitting around that table in your institution, you can befriend the case manager, social worker, whoever is leading that, but then also your other rehab friends to advocate, because OT and PT is almost always around that table. So I will give it over to Dr. Reedy to address what she most wants to address from her section.
Yeah, so I think that there were just some general questions about, timing of events and, is there overlap between where the speech pathologist sort of fits in the screening process, and even like there was a question of when to screen or when to pick which sort of thing to do with the patient, right? So screenings are not redundant to the clinical evaluation. They are separate and distinct. Screenings can be done by any medical professional who's trained to do them. Sometimes speech pathologists are the people to do them, but at least in our institution, we work day shift. And so if a patient comes in, at 7 p.m., we want to be able to one, quickly identify, do they have, are they looking like they have dysphagia, right? Which can help inform the care team about being more proactive about their care. And then two, could they get dinner, right? Could they have those medicines, right? Can they consume something, right? And that's really important. And then the speech pathologist role is that if the patient failed at any point, right, whether or not they look a lot better 6 hours later, that the speech pathologist really should still be seeing every single patient who has failed the swallow screening, regardless if I go in and I say, yep, I think that they look fantastic, because there's a lot of nuance, right, in terms of what the speech pathologist is looking at. I practice based on risk factors, right? So really looking at a lot of things that aren't included in the screening, and that the screening should and can be readministered as many times as needed. However, should not be readministered on patients who are already on an altered consistency or already recommended to be NPO because of the speech pathologist recommendations. That's like the hard stop for that.
I think I'm next. So there were some really great questions in the Q&A, and I think conversations that all of us have had with one another about, particularly around availability of radiology scheduling, repeating imaging assessments. So I'll kind of cover both of those. So someone asked a question in the chat. They're at a kind of remote care facility and they have one MBS day per week. That's really challenging. So first, I think I answered the question in like the answer to the question is, what the question was, can fees replace MBS in this case because we only have one day of access to fluoro? So the answer to the question is no, fees cannot replace MBS. But the caveat to the answer to that question is recognition of the fact that you have really, really limited access to MBS. And I'm sorry, that really stinks. And I know that you know that if you had better access, you would use it more often. So I think that this is happening to people across the country. It's happening to us here. There's articles, there's an international shortage of radiologists in the world they're struggling to keep up with all the radiology needs and procedures and image reading. So it's a thing that's actively happening right now. I anticipate that there may be a shift and a change over time in sort of ownership of this procedure, and we're actively talking with radiology leadership about how do we come together at the table to really meet both of the needs that we have in this space. So hopefully there'll be some solutions in the near future, but at current state, this is happening everywhere, even in major care centers that have good access to radiology equipment and staffing, much less in remote settings. So again, the short answer is no, fees can't replace MBS and MBS can't replace fees. We really need access to both of them. In an ideal setting, we would be able to do them on every single patient whenever we needed to, and we know that that's not the reality current state. But I think continuing to have those conversations with your radiology department and those leadership positions, explaining why they're different, just keeping that broken record conversation going, I think over time we'll see a shift. But also acknowledging that you have to do the best that you can for the patients that are in front of you today. So appreciate the challenge.
Yeah, great points, everyone. I'll just address kind of a double question here. One was someone asking about specific tools or equipment or types of toothpaste and stuff that you should use. One, use what you have in your facility if it's appropriate for your patient. You likely have, toothbrushes. They typically are softer. If a patient brings in their own oral care equipment, great. That's what they're used to. So use what you have in your facility. Often these patients don't need anything specialized unless there's other infections or anything else going on. If they have thrush, chat with your medical team and doctors to determine what other types of oral care solutions they might need. There was a note on one of my slides about not using chlorhexidine. That comes from a CDC recommendation that they have moderate evidence that chlorhexidine can increase mortality. I don't have much more research myself on that, and I can dig a little bit more into what that looks like and why and where they get that information. I think when we pair oral care with a with a solution, right? Like when patients have thrush and they might get the magic mouthwash or swishes and spits and stuff like that. Nurses and staff are more likely to do it because it's an order that comes with a medication or a tool. Oral care may be more likely to be done if it's ordered with something like that. Oral care it shouldn't be the case. Oral care should be done. It should be priority. It should be in order and have the same level of importance as it would if it were paired with a medication or something that came from a pharmacy. And that's the goal that I think we should all get to, is that we have an order for oral care. We need to do it.
Well, it is 12:30. If you guys want to answer any last minute questions, you can, but I know some people have to leave us. Caitlin, what do you think? Should we wrap up, or do you guys want to answer any other lingering questions?
I don't know if Yanina got a chance to answer.
I think Yanina didn't. Let's let her have one quick chance.
Absolutely.
I think I answered some questions in the chat. Which one do you like me to address?
Maybe is there an overarching theme of questions you feel like you saw, Yanina, or you answered? Or a high impact?
I think so many questions were with the meds, NPO except meds. So I think we've addressed that one. And we had another good question from someone who asked when actually aspiration pneumonia or pneumonia is most common after stroke. And it seems to peak around 3 to 4 days after stroke. So that's like the most frequent time. And that's not just because of dysphagia, but lots of other factors that also contribute that a patient has worse defense mechanisms at that time.
Yeah, absolutely.
Well, thank you guys all so much for sharing your expertise. I know I personally learned a lot in the last hour and a half, and I think by the look of our Q&A, everyone else did as well. So thank you guys for taking time out of your schedule to present to us. Thank you to everyone who attended for joining us, and we look forward to more webinars in the future on topics such as these. So thank you, everyone. Quick note on CEs, because a few people did ask. We will send out information after the webinar today on how to claim your continuing education units. If you attended live, you are eligible for those. It does take a bit for the American Heart Association to process kind of the list of who attended. So look for an email by the end of the week, even early next week. If you don't see it, then feel free to reach out to any of us. Caitlin, anything you'd like to add?
No, thank you everyone for attending. I appreciate everyone who came, who registered, who might watch these recordings later. And then thank you again to all of my colleagues sharing the stage, all of us together. It's incredible that we can share this information that's so important and passionate to us and can help all of our stroke patients. And hopefully we can make this bigger impact across the nation and the world.
Awesome. Well, thank you all and have a wonderful day.
Thank you.